Hi, I am Sheryl Sodorff, and I work with the development team at Willamette Valley Hospice and Palliative Care. This video is Understanding Hospice, also known as Hospice 101. This is your orientation for hospice and how our hospice team will support you and how we work together. So let's get started on defining hospice. Hospice is specialized care and support for anyone, adults and children. Hospice is a philosophical choice, a way of living the last phase of life. Our experienced hospice staff guides patients, families, and caregivers through every step of this journey. We empower patients and families to experience life's final moments and months according to their wishes, with the utmost comfort and dignity. We educate on what to expect at each stage and provide physical, emotional, and spiritual support, all while managing pain and other symptoms. We support families on their path to healing once a loved one has passed. Philosophy and guiding principles. Hospice recognizes dying as a natural part of life and focuses on maintaining quality of life. Hospice affirms life and neither hastens nor prolongs the dying process. Hospice is patient and family-centered, palliative and holistic, focusing on physical, psychological, social, and spiritual well-being. Hospice is about comfort care rather than curative care. Who is eligible for hospice? 2 physicians certify that the patient is terminally ill with a life expectancy of 6 months or less if the disease follows its normal course. Patient and/or family are aware of the prognosis and choose to elect comfort measures. Patients are eligible for 2 90-day benefit periods, followed by unlimited 60-day periods. Who pays for hospice? Hospice is a benefit covered by Medicare, Medicaid, the VA, and most private insurance plans. As a not-for-profit organization, we are committed to making sure our patients and their families receive the support they need, regardless of their ability to pay. Hospice interdisciplinary team members, that includes the patient and family, caregivers, primary care physician, hospice physician, registered nurse, case manager, medical social worker, a hospice aide, a spiritual counselor, maybe a dietitian, certified pet music and massage therapists as needed, and bereavement counselors. The location is always where the patient lives. We go to the patient. So the patient's home, nursing facility, that can be assisted living, adult foster home, the hospital, anywhere the patient calls home. Levels of care. Routine provided in a patient's home, ICF, or a care facility. Respite provided for up to 5 days to relieve caregivers. Continuous, short-term, highly intensive nursing in a home for an acute crisis. General inpatient care is short-term care provided in the hospital or SNF for an acute crisis. The role of Willamette Valley Hospice is to support the cultural and spiritual orientation of the patient and family, to assist the resolution of interpersonal and internal conflicts before death, to help attain a degree of peace in search for the meaning and purpose of their lives, to help the patient and family achieve a positive and end-of-life experience that is defined by them. Identifying hospice patients, decreased oral intake and appetite in the past 2 to 3 months, weight loss of 10% or more over the past 6 months, decrease in functional abilities and ADLs, activities of daily living, history from patient and family of specific decline in condition, multiple hospitalizations or emergency room visits, and or increased calls to their doctor's office, recurrent infections with lack of response to treatments. Now, signs: patient may have pain, frowning or grimacing, moaning or crying out, flinching, guarding, holding a part of the body, shallow and rapid breathing. These are things you can notice when they cannot verbalize what is going on. Common side effects of pain medication: drowsiness at the introduction of a new pain medicine or dose increase in the last day or two, nausea, anti-nausea medication, or taking a bit of food with the pain medicine may help, constipation, daily laxatives or stool softeners per nurse instruction, dry mouth. This is very, very common. Ice chips, hard candy, gum, fluids, and a good mouth care may bring relief. Difficulty with breathing. Adjust positioning in bed or chair and raise head with pillows or raise the head of the bed. Use a fan to increase air movement. Implement oxygen as ordered, but do not adjust the rates without the nurse provider approval. Give medications as ordered by nurse provider. Stay with the person, speak calmly, and give reassurance. Quiet music may help a person relax. Loss of appetite is natural for the body's metabolism to slow. During this time, the most common reasons for lack of appetite or fluid intake include disease progression, dry or sore mouth, nausea and vomiting, pain, constipation, and depression. Taking care of someone in bed. As people become weaker, they cannot move easily on their own, and changing positions with even small changes can relieve pressure. Your nurse or aide will show you how to safely turn or move someone in bed. Explain ahead of time what you're going to do. This is very helpful to the patient. Check the area and make sure that tubing will not be kinked, blocked, or stretched if there is any. If moving in bed causes a person pain, provide pain medicine 30 to 45 minutes prior, with approval by the nurse provider. Recognizing the signs and symptoms of dying: increased sleeping and withdrawal, decreased fluid and food intake, tolerance for food and fluids diminish during this time. Eating may become more of a burden than a pleasure. And there can be a feeling of being full very quickly. Disorientation and confusion. Restlessness and agitation. These may include pulling at the bedding, picking at the air, trying to prevent restlessness and agitation. Incontinence, loss of bladder and bowel control is common, and output may greatly decrease. A catheter may be needed. Congestion and changes in breathing. Breathing may become more irregular, shallow, and have long pauses. Throat muscles become relaxed, and the lungs may lose their ability to clear fluids, increasing sounds of congestion and rattling in the throat. Body temperature changes and mottling of skin. Heavy perspiration, cooling and warming may occur. Bony areas such as hands and feet may have a violet color or a bruised appearance. Dryness of eyes and mouth. Crust may form on eyelids. Eyes may remain partially to totally open with no blinking. Mouth breathing is common as the lower jaw relaxes, creating a dry mouth. Visionary experiences. Often the patient may see or speak to people from the past, or making out-of-character statements or requests is not unusual. This does not indicate hallucination or drug reaction. Tending to hold on or needing to say goodbye. Recognizing signs and symptoms of dying and preparing the family for these changes will often help families understand the dying process and therefore hopefully have a better experience with the death. After death occurs, stay calm. Follow policies. Call hospice to have a nurse come for staff or family support. There is no need to call EMS. You or hospice team members notify designated family members. If you need help with that, ask. You or hospice team members call the mortuary when the family is ready for the body to be picked up. You or hospice team member can prepare the body for family viewing by bathing, putting on fresh clothes, changing linens, combing hair, and giving oral care. Give family plenty of time to say goodbye. Willamette Valley Hospice staff will notify the attending provider and the county medical examiner's office according to law. The mortuary will arrange to have the death certificate signed. Medical equipment is normally picked up the next day. If there is a problem, please let the hospice team know or call the Willamette Valley Hospice office. Please note, it is a family's perception about the death that determines whether the death was good or peaceful. Not all deaths are good. Medication destruction. This is very important. Our team goes through this with your med tech, but we want to be sure that you're clear on it, and you may always ask questions. You may be asked to destroy medicines, especially narcotics, as a safe measure to adhere to drug enforcement laws. Refer to medication safety training and ask the nurse if you have other questions. Remove and destroy identifying personal information from all pill containers before throwing them in the trash. And do not flush the meds down a toilet. Deliveries after death. If any deliveries of medicines or supplies arrive after death, please refuse the delivery and they will be returned to the supplier. Now, a very important one. I'm sure you've gone through training with infection control during this COVID-19 time. This is something that we need to go through briefly, and it's in your handout completely, so you can always refer to it, but critically important and very much expected. If you get surveyed, they want to see what we have talked about. So let's talk about infection control. Hand hygiene is one of the most important ways to prevent the spread of infection. Must be performed before touching a person, before providing a clean aseptic procedure, after direct contact with body fluid, after touching a person, and after touching surrounding surfaces. Very important. Environmental cleaning. Pathogens can survive in the patient care environment for long periods of time. Environmental contamination leads to healthcare personnel and patient infections. Standard precautions and PPE, personal protective equipment. Following standard precautions is the first line of defense to break the chain of infection and assumes any body's blood or body fluid may be infectious. PPE worn should be based on the level of anticipated contact with the patient and the potential for exposure to infectious material. Gloves should be worn when anticipating any contact with blood or body substances. Gowns should be worn when contact between clothing or skin with patient blood or body substances is expected. Face mask and eye protection should be worn when anticipating potential splashes or sprays of blood, body substances may occur during patient care. Targeted infection prevention strategies. Catheter-associated UTIs. Indwelling urinary catheters should only be placed when ordered. Proper aseptic insertion technique and maintenance procedures should be followed. Again, communicate with and talk with your nurse provider. MRSA infected patients should be placed in contact precautions and placed in private rooms or cohorted with similarly MRSA infected patients. Patients with C. diff should be identified early. Contact precautions should be limited and initiated, and appropriate cleaning and disinfection of the equipment environment assured. Patients, families, and caregivers need to be taught to actively engage in infection control practices. Don't assume that they are doing what they're supposed to be or that they know what they're supposed to be doing. Always, always actively engage them and gently encourage them that they need to have a mask on or that they need to have gloves on for something in particular. This is for their safety as well as yours and the patient. For more complete training on infection control, you can refer to the CDC website. Now, patient rights is something that's critically important and in our patient handbook. I won't go through all of these patient rights. You have a clear list in your handout. And again, it's in our patient handbook, which you're going to have 2 or 3 copies of in your community that you can refer to and or share with someone who is considering hospice. We always give a patient handbook when we discuss with them and educate them on hospice. So the patient has a right to always receive written information describing our grievance procedure, which includes the contact information, phone number, hours of operation, and mechanisms for communicating problems. Receive a copy of the Willamette Valley Hospice Patient Handbook. This is important that they must receive this copy of this handbook. We give it to them, but you will have it to access. The patient has a right to expect that we will always protect and promote the patient's right to exercise their rights. They will never have a change in their care or how they are treated simply because they have a grievance. If they have a complaint, they should feel absolutely confident and comfortable to complain about something. Maybe there's something they don't understand. Maybe their pain has changed and it has not been noticed. There could be a number of things, but they will never have a change in how they are treated and should never feel uncomfortable with someone coming into their room in your facility. If any of that occurs, you or they and the family need to tell us immediately, because we will get to the bottom of it and make sure that we know what's going on, or if we have to, we will change out the person that is delivering the care. Comparison of responsibilities is something that is in the contract, attached to the contract that we go over with your administrator. It is required by Medicare and Medicare facilities. So it's called Comparison of Responsibilities. And it's quite a lengthy list, and it has you in one column and hospice in another column. And there is an X in the column indicating who's responsible for this particular thing. And we both have X's when we both do it simultaneously and support each other. So it's a lengthy list, and I won't read it line by line, but I want you to know that this is critically important for you to go through. It is also a great training tool to have in a staff meeting or an orientation. It covers from A to Z what is expected in our relationship. Oftentimes, communities do not understand really how it's supposed to work when hospice comes into your building. And so we want to make sure that you understand and feel very comfortable with how we're working together and should be working together. Of course, we have a written agreement that prior to starting to provide hospice services. Documentation of communication between hospice and the SNF to ensure that patient needs are addressed 24 hours a day. The documentation is critically important. So both of us, hospice and your facility, need to make sure that our charting and our notes are very, very thorough. And also the plan of care, as we refer to the POC, that plan of care has to change when something changes in the care of the patient. Change in medication, change in what we're doing, changes with the patient that are significant with oral intake. So these must be documented and charted. And the person coming on the next shift should be able to easily read that and know what has occurred and what has changed, and not assume anything, or if they don't cross over with the person going off shift in any way, then they are responsible for reading that plan of care. It's critically important. Immediate communication to the hospice by your staff. If there's a significant change in the patient's physical, mental, social, or emotional status, clinical complications that suggest a need to alter the plan of care, a need to transfer the patient from your community to the hospital, or the patient died. I know these may seem obvious, that it would need to be communicated, but you know, when you work the second shift or the knock shift, these things happen, and you take good notes and you try to get everything in, but nothing is communicated orally to someone else. And there's nothing like having some good communication about major changes with a resident and a patient. Responsibility for determining the appropriate course of hospice care, including determination to change the level of services provided. That's our responsibility, hospice. 24-hour room and board is your responsibility. And that doesn't change from when the person first moved in to now being on hospice. Hospice services at the same level, to the same extent as the services that would be provided if the resident was in his or her own home. This is their home, and we want them to feel very comfortable in this home, and you do too. Hospice plan of care must identify the care and services that are needed and specifically identify which provider is responsible for performing those respective functions that have been agreed upon and included in the hospice plan of care. We're both responsible for that. We're both responsible for making sure we know what's in that plan of care and that everything that should be is. Orientation, like we're doing now, and training of your staff is definitely something that is our responsibility. And we want to make sure that there is no questions that go unanswered or anyone feels bad that about asking a question or that they can't ask a question. Absolutely, you can ask questions. And when we're not here in your community, you need to give us a call. Call for your nurse. Whoever answers the phone at Willamette Valley Hospice will find someone for you and someone to get a message to your nurse when needed, or one of our clinical managers. Now, there are many other things in between on those responsibilities, very clearly spelled out, should be very clearly understood by everyone. And we want to make sure that you have this video so that you can access it whenever you want. You can watch it 2, 3, 4 times. You can look at it once a month. It can be used in trainings, in staff orientation, and be, I hope, very helpful to you for the next 12 months that we are a partnership in meeting Medicare requirements and delivering proper care to your residents. Thank you for spending time with me. I know you may have a lot of questions, and if you have questions, please feel free to write them down. You may email me, you may give them to your administrator, and I will answer them or have someone on the team answer them for you very quickly so that you feel that you got your question answered and that you understand what is supposed to happen. I look forward to a better year this next year, but we're still closing out 2020, so we need to do these orientations. And 12 months or less, we will need to do an orientation again and talk. So thank you for what you do, the support that you give your community, the support you give the families, and most importantly, the support and care that you provide your residents. You're in a special situation, you're unique, and it's really important what you do and what they receive. And we want their end of life to be a high quality of life as it can be for them and comfortable. Thank you. Willamette Valley Hospice thanks you, and have a great rest of your year.